associate professor in Aachen, who's going to present cases from real life, the cases that we have discussed in multidisciplinary team meeting. And we have faculty, including Dr. Khurram Siddiqui, who is a consultant urologist at Sultan Qaboos in Oman. He's an AKU alumnus, and he has a special interest in testicular cancer. We have Dr. Bilal, who is our moderator and coordinator of the MDT, of the tumor board meeting, and he's a radiation oncologist. Bilal is a very academic person, and I think he will give a wonderful input on the management of these cases. We also have Dr. Imran Ahmed. I hope he has joined. Dr. Imran is a medical oncologist, and we know that it's a multidisciplinary management of the testicular cancer. So I hand over mic to Dr. Nazim to please start off with the cases. And I encourage all the participants to please post your questions on the chat box, and we will be monitoring and forwarding it to the faculty for discussion. So thank you to all participants. And you'll be surprised to note that we have nearly 200 registrants for this course. And I hope that most of you will be able to join. We already have over 60 people. So Nazim, over to you.
Thank you very much, Dr. Hammad. I hope I am audible. Right, so let me share my screen. I hope my screen is visible.
Yes,
it is.
Right, so as Dr. Hammad has mentioned, this is about the interesting cases of the testicular cancer that we have seen. These are the real life cases. So I will start with the first case. This is a 29-year-old gentleman who is electrician by profession, resident of Hyderabad, and married for 5 years, and has 2 kids. However, his family is not yet completed. So he presented in clinic with complaint of left-sided painless testicular swelling, which he noticed for last 3 months. His past medical surgical history, drug history, and family history was unremarkable. And on examination, his left testis was enlarged. It was firm in consistency, non-tender, with negative trans-illumination test. And the abdominal examination was essentially unremarkable. So he had an ultrasound of testis, and it showed that this is the ultrasound of the testis, and this is left testis. And here you can see that the whole of the testis is replaced by a heterogeneous echogenicity. Unfortunately, we do not have the color Doppler image, but on Doppler it showed vascularity. This is the ultrasound of right testis, and surprisingly here you can see a mixed echogenicity lesion, which is a bit deeply placed. It is not closer to the tunica albuginea. It's a bit deeply placed, and the size is approximately 1.2 by 1 centimeter in the right testis. So he had a CT scan, chest, abdomen, and pelvis, which was done from outside, and it showed that his left testis had a heterogeneous mass 7 by 5 centimeter in size, without any retroperitoneal lymphadenopathy. His abdomen revealed no lymphadenopathy. The solid viscera were normal, and the lungs were also normal. The tumor markers showed raised alpha fetoprotein more than 2000, with a slightly raised LDH and beta HCG of 1542. So what are the treatment options? I would request and ask Dr. Khurram Siddiqui to tell. This is a gentleman with left-sided testicular swelling and an incidental diagnosis of a right-sided mixed echogenicity testicular tumor, mixed echogenicity lesion with raised tumor markers.
Nazim, sorry, I kind of, lost you in between. So I couldn't hear the full history, but I believe that this is a youngish, like a middle age. I couldn't. I lost you in between. Yeah, because
So this is a 29-year-old gentleman with 3-month history of left-sided testicular swelling. And ultrasound showed that entire testis was replaced by a mass, and right testis incidentally showed there was no palpable lesion in right testis, but right testis showed a deep-seated 1.2 centimeter lesion of mixed echogenicity. His tumor markers were raised with alpha fetoprotein around 1,500, beta HCG around 2,000, and LDH was also marginally raised around 430.
Yeah. So obviously this is a case of mixed germ cell tumor. And the concern here is that are we dealing with a unilateral disease or are we dealing with a bilateral disease? And certainly we all are very clear with the treatment of unilateral disease, but am I audible to all, or is there a issue?
No, no, you're audible. Khurram, please go ahead.
Yeah, sorry. I just saw the kind of, the chat box about the audibility. So I thought probably that. So yes, the issue here is that, the unilateral tumor, of course, will be managed with an inguinal orchidectomy and then followed by tumor markers and their kinetics. We have already done a CT scan of the chest, so and excluded that there is no supradiaphragmatic disease in this regard. So once the diagnosis of mixed germ cell tumor is established with an orchidectomy, the question really arises what to do about the contralateral side. Is there a tumor there, or is this something which is instantly picked up? Now, there are certain risk groups in which even if you don't have any radiology. But it is kind of, it is visible on the ultrasound. So yes, the treatment is inguinal orchidectomy of the 7-centimeter tumor, and followed by markers surveillance, and then taking up from there. However, the other side needs to be biopsied if it has a tumor, to exclude a germ cell neoplasia.
Thank you, Dr. Khurram. So just a slide about the small testicular tumor. So as Dr. Khurram has mentioned that tumor incidentally diagnosed asymptomatic non-palpable testicular lesions, which are less than 2 centimeters, are mostly benign in up to 80% of cases. However, no imaging technique can clearly define the nature of the lesion, whether they are benign or malignant. So there are multiple studies, including the systematic reviews and large retrospective analysis, which have shown that there are bilateral chances of bilateral testicular cancers in about 1 to 4% of cases. And EAU guidelines recommend that testicular sparing surgery is a viable alternative to radical orchiectomy, particularly in cases when there is synchronous bilateral testicular tumor, a metachronous contralateral tumor, or tumor in solitary testis with normal preoperative serum hormone levels whenever the tumor volume is less than 30% of total testicular volume. So this case was discussed, and the decision was made in our tumor board meeting to go ahead with right-sided organ preserving, that is partial orchidectomy, and left-sided radical orchiectomy. So Dr. Khurram, any thoughts about that? You said that for the obvious tumor on the left side, left radical orchidectomy should be done, and the right should be monitored, and later on a biopsy can be done if the markers are rising and so. Dr. Khurram.
Yeah, yes. So especially for the trainees' point of view, there is a role of the tumor markers pharmacokinetics, or the kinetics of tumor markers and the half-life of each one of them. And it is important, nowadays when we use, we just order CT, chest, abdomen, pelvis, in times where you only ordered for chest, for abdomen and pelvic CT, followed by an orchidectomy, then the tumor markers were important. How do they come back to normal? We know that the half-life of alpha-fetoprotein is about 5 to 7 days, and beta-HCG has a even shorter half-life of about maybe 24 to 36 hours. Now, if the tumor markers after your surgery are not normalizing in the half-lives multiplied by 3, that means that you have some disease elsewhere. And then you need to look at the contralateral side much more carefully. Now, there are pros and cons of kind of, doing the procedure simultaneously and staging it into kind of, 2 procedures. Once you do the right side, the left radical orchidectomy, and then you can have some time to think about what you want to do for the other side. You can look for the tumor markers, how they are coming back to normal. You can use the time in between for preservation of sperm, for the sperm semen banking, and you can later on explore the other side, provided all the criterias are there. Certainly, there are certain risk factors which increase the likelihood of presence of a tumor in the contralateral side, and size is one of them. If you have a testis, a contralateral testis, which is less than 12 ml if in volume, there is a higher chance of harboring, intratubular neoplasia. And in those cases, you are required to biopsy that side. And similarly, if there is a history of cryptorchidism and this testis was brought down from abdomen or from some other locations, then there is an indication for biopsying the other side. However, doing it at the same setting, you have one anesthesia. However, you can do it in 2 settings as well. I don't know what, I think you proceeded with simultaneous surgery.
Yes, Dr.
Khurram, there is
Yes.
a question, and I think it is pertinent for what is being discussed so far about the testis sparing orchiectomy, the approach. Maybe a few points before Nazim can move on with the presentation.
Well, there are certain criteria which fit into testis with the testis sparing approach. One of them is that size of the lesion itself. Anything which is more than 2 centimeters, it's very difficult to preserve the testes in those cases. And similarly, size itself is sometimes not the sole criteria. You have to look at the whole size of the testes. A 2 centimeter or even a 1.8 centimeter lesion in a smallish testis would kind of, remove bulk of the functional component of the testes. So you will be left with almost no functional tissue at the end. So 30% is something, if the size of the tumor is around 30% of the volume of the testes, or it is less than 2 centimeters in a normal size testis, you would kind of be inclined to proceed with a testis sparing approach. Now, in the testis sparing approach, everything else is the same. You have to, although you are biopsying the testis, but it is not a transscrotal biopsy. It is an inguinal biopsy again, in which you have to explore through the groin, deliver all the testes with all the tunical coverings in the groin, cover the wounds to avoid any spillage. Some people tend to cool the testes after putting a soft clamp at the high ligation area. And then, you explore through a vertical or a horizontal incision, and then you probe where it is. It is important that you have expertise and facility to do ultrasound intraoperative. If you don't have an intraoperative ultrasound, just palpating the whole testes for a non-palpable, initially non-palpable lesion would make a lot of mess, And then once, even when you identify with your ultrasound and you remove the mass, you have to do some biopsies of the bed of the tumor as well to look for GIN. Now, if there is GIN, then this patient would benefit from adjuvant radiation along with your testis sparing approach. So these are the kind of important points. You don't only want to remove the visible tumor, you want to know if there is any residual or any evidence of TIN in the or in situ tumor in the bed, as well as you want to kind of preserve a functional tissue, which if you are not ending up with any functional tissue, then risking a higher risk of local recurrence is probably not worth it. And that's why testis sparing approach has not really picked up in a big way in germ cell neoplasia.
Thank you, Dr. Khurram. So the key points you mentioned that number one, there should be an intraoperative ultrasound. It should be an inguinal approach, and there should be a frozen section, and one must be sure that there is no concomitant tumor in testicular intratubular neoplasia. So there is one question from the audience is, and I think Dr. Bilal can answer this. So let's suppose that, let me go to the histopathology of this tumor first. So the left testis showed that it was a malignant mixed germ cell tumor comprising 40% of embryonal tumor, 30% of teratoma, 20% of yolk sac tumor, and 10% of choriocarcinoma. And the right testicular tissue, which was biopsied, showed only a benign mucinous cyst. So let's suppose that on the right side, if it is testicular intraepithelial neoplasia, so what is the role of radiation therapy, Bilal? And how much dose of radiation would you give to the testis?
Thank you, Dr. Nazim, for the query. Yes, radiation therapy has been used for a curative approach for treating testicular intraepithelial neoplasia when you have a second lesion with one tumor, one of the testes affected with a germ cell tumor. The dose used for treating TIN is actually 20 gray with conventional fractionation of 2 gray per fraction. But remember to note that the radiation would result in hypogonadism following radiation therapy. This particular patient was of childbearing age and has not been married up till now, so there would be infertility following radiation therapy. That is of particular note for this.
Right. So this gentleman has a T1 and not M0 disease, no lymphovascular invasion, so stage 1A. Subsequent follow-up showed that his tumor markers were all normal. He is currently kept on surveillance with tumor markers and radiology, and he is in clinical and biochemical remission. So, Dr. Hammad, can we move on to the case number 2?
Please go ahead.
So the case number 2 is about a 19-year-old boy who is single, and he noticed a right-sided testicular swelling some 4 months back, which is painless, and he denies any history of weight loss and any other constitutional symptoms. His past medical and surgical history is unremarkable. However, he has a positive family history of testicular tumor in one of his paternal cousins. So on examination, the right testis was enlarged. It was firm to hard in consistency. It was non-tender. The abdominal examination and the supraclavicular exam and the lymph node examination was unremarkable. So he had an ultrasound scrotum which was done outside AKU, and it showed a right testis which was enlarged in size, and there was a heterogeneous solid lesion about 3.5 into 3 centimeter, which showed vascularity. His tumor markers, particularly alpha-fetoprotein and LDH, were raised. And we proceeded with right inguinal orchiectomy first, and it showed a malignant mixed germ cell tumor, which comprised 80% of immature teratoma, 10% of yolk sac tumor, and 10% of seminoma, along with intratubular germ cell neoplasia. The tumor size was 4.5 centimeter in the largest dimension. However, there was no lymphovascular invasion. Spermatic cord and dissection margins were tumor-free, and there was no invasion in the epididymis. So again, this was a T1NX-MX disease. So following the orchiectomy, he had a CT scan, chest, abdomen, and pelvis done. So this is the CT scan of chest, and in the upper cuts in the lung window, you can see that the lungs are clear. There was no evidence of any infiltrate, no hilar or no hilar lymphadenopathy, and there was no abnormality in the pleura. There was no pleural effusion. This is the CT scan of upper abdomen and the solid viscera. The blood vessels and lymph nodes were normal. There was no lymphadenopathy in the para-aortic, in the pelvic, or in the inguinal region. The bladder and seminal vesicles were normal. Similarly, this is the chest X-ray, posterior anterior view, which was normal. So following that, the case was discussed in MDT. Following the orchiectomy, in 2 weeks' time, his alpha-fetoprotein and beta-SCG, which were initially raised, came down to the normal levels. So this was categorized as a stage 1A non-seminomatous germ cell tumor. So Dr. Bilal and Dr. Imran, what are the options now in this young 19-year-old gentleman who has a stage 1A non-seminomatous germ cell tumor? The testicular tumor markers are normalized after orchiectomy.
This is Dr. Imran. For this patient, can you hear me?
Yes, Dr. Imran, please go
Yes.
ahead.
Okay. So for this patient with stage 1A non-seminomatous germ cell tumor, I think there are 3 options that can be discussed. One will be the surveillance. Another will be to consider Rplnd. 2 options actually, yeah, surveillance and Rplnd. But for the stage 1A disease, if the patient is young and he can have good follow-up, I think surveillance will be considered as a better treatment option, considering if the disease relapses. So with surveillance, I think the risk of relapse at this stage of this patient is approximately 20 to 30%. And with the adjuvant treatment, if you want to consider adjuvant treatment with the chemotherapy or Rplnd, the risk will go down. But even after the relapse with the surveillance strategy, the risk of salvage with the chemotherapy will be approximately, the benefit will be up to 90 to 95%. So I think surveillance will be a good option for this patient. And if the patient can have good follow-up with the CT scans.
Thank you, Dr. Imran. So there is one question from the audience is, what about the role of single cycle of BEP, bleomycin, etoposide, and cisplatin?
Yeah.
Dr. Imran?
Yeah, the single agent BEP can be considered in this patient as I mentioned, adjuvant treatment, and it increases the chances of cure, and it can go up to 90 to 95%. But again, it has its toxicity. And if you think that the patient is coming from, an area where the CT scan coming back for the follow-up would be not good thing for him, or will be very difficult for him, then I think one cycle of adjuvant BEP would be reasonable option. But still, I will give priority to the surveillance for this patient if it can be done like that.
Thank you, Dr. Imran. So the patient...
I have a question here. In the pathology, you have like a predominant teratoma, a mature teratomatous component. So what is your opinion about such a pathology and, RPNLDs? Hello.
Hello, is this question for Dr. Nazim or for me?
Prof, for you also, you can also kind of
Okay.
chip in.
Yeah, so I mean, teratoma, yeah, I actually missed the earlier part, which shows the pathology, but teratoma doesn't change the whole management plan. I mean, it will still fall into the category of non-seminomatous germ cell tumor. Yes, what happens with the teratoma that there is always, if it is really true teratoma hiding in the lymph nodes, then it will not respond to chemotherapy and it will grow. But I don't think it will sway me to one or another direction. I think surveillance would still be the reasonable option.
Right. So the patient opted for surveillance, and in about 3.5 to 4 months' time, he had a repeat CT scan, chest, abdomen, and pelvis, along with tumor markers. So this is CT scan chest. The lung window again showed no abnormality, no nodules, pleural or lung bases, no hilar or mediastinal lymphadenopathy. However, here in the CT scan of abdomen, you can see that there is a hypodense area, apparently a necrotic lymph node in the interaortocaval window, which was measuring about 20 by 16 millimeters. And this is the coronal view. Here you can see a necrotic lymph node in the interaortocaval window. And so this is now a stage 2A. His tumor markers were normal. Sorry, I just forgot to mention that. So this is now stage 2A S0 non-seminomatous germ cell tumor. So what are the options now, Dr. Khurram? So within 4 months, he developed some lymph nodes in the interaortocaval window. In the
certainly, that the tricky question was that, to assess what is the metastatic potential of this disease. A young patient with, fertility at stake, at least for some time, if you give him chemotherapy, so your dilemma is to overtreat or undertreat, so in this, the consensus opinion earlier was that, maybe we should hold on to the chemotherapy and give him some quality of life or in between. However, we obviously underestimated the metastatic potential here, and now there is a lymph node with the normal markers, is still normal markers. So with the pathology, being predominant teratoma, I would consider, surgery over chemotherapy here, because if the markers were a little bit raised, then there could have been a case where you think that there is a germ cell component in that metastatic looking lymph node. However, now your tumor markers are normal and you have progression of disease in the retroperitoneum, which suggests that there is probably disease like teratoma there, which may not respond to chemotherapy. So this is, in my opinion, a case for retroperitoneal lymph node dissection. It can be, template base. In this case, it doesn't need to be a bilateral one, and so that we can kind of preserve the nerves and ejaculation and etc. etc. It will give us good pathology specimen to kind of tailor further treatment as well.
Dr. Imran, what is your opinion?
Yeah, I agree with that, in the presence of normal tumor markers, I think Rplnd, either template one or bilateral would be the best option. And if we find there are some active germ cell tumor beside teratoma, then patient will still need some adjuvant chemotherapy. If we find only teratomas, then I think Rplnd would have done the job.
So there is a question about, Khurram, this is directed to you, about Rplnd prior to the first follow-up CT scan. So when there is no visible lymphadenopathy, what is the indication and purpose of an Rplnd?
So this is what we call primary Rplnd. Primary Rplnd is one in which chemotherapy is not considered. It's a diagnostic procedure. Now, if you look at the the indications for RPNLD, they are based on size on CT scan. And size itself, we know, is not the kind of, the 100% indicator whether, there is tumor in that enlarged lymph node or it's a reactive lymph node, or what about lymph node, which is like 8 millimeter lymph node, 8 millimeter lymph node. Is it just a reactive lymph node, or does that harbor any evidence of malignancy in that? RPNLD answers those questions. If you do an primary RPNLD, you are likely to kind of, accurately sample those 4 millimeter, 6 millimeter, 7 millimeter lymph nodes, and you may be able to detect disease which earlier than what it may present with later on during surveillance, or if you unfortunately miss one follow-up appointment, your disease may present again to you with a higher burden. So a primary RPNLD has 3 or 4 advantages. You are very sure about, you're 100% sure about the stage of the disease. And if you, and depending on the specimen, you can offer chemotherapy to a selected individuals who have disease in the retroperitoneum, and avoid over-treating those who do not have any disease. And certainly in certain proportion of these individuals, you can also cure the patient if there is minimal disease in the retroperitoneum in primary RPNLD. Of course, the drawback is that it is a morbid procedure, a big incision usually, and in this age, ejaculation is at stake. So so these are the side effects which prevent us from using RPNLD in all these other individuals. Plus, the chemotherapy response is great. Even if you miss it for a few days, 2 centimeter lymph node becomes a 3 centimeter lymph node. It's still, the chemotherapy is so effective that maybe we will be able to offer this individual a good quality of life and longevity, even if we kind of, miss disease at 8 millimeter, 10 millimeter stage. So that's why, primary RPNLD is not a very commonly taken up procedure, and it has been replaced by, in most of the centers, by chemotherapy. But certainly it does have advantages. It makes the surveillance less intense. And another factor which is present in testicular cancer follow-ups is the use of CT scans and radiation associated with repeated use of CT scans, which predispose one to development of secondary malignancies in the region of the abdomen where multiple CT scans were done. So a lesser intense follow-up is also can be tailored if depending on the results of RPNLD.
Thank you, Dr. Khurram. So this case was actually done 4 years back. So this case was discussed in tumor board, and the options were discussed, and the patient opted, although it was teratoma 80%, but the patient opted for chemotherapy, and he received 4 cycles of bleomycin, etoposide, and cisplatin. Following the completion of chemo, his beta HCG and alpha fetoprotein were normal, but LDH showed a rising trend, and it reached up to 800 international units per liter. Again, a CT scan, chest, abdomen, and pelvis was done. CT scan, chest, lung windows were all clear, all normal. However, there was an interval progression of this necrotic lesion. So previously it was around 2 centimeter in size. It grew up to about 29 millimeter or 3 centimeter in size. And along with that, there was development of another necrotic lymph node just inferior to that, and it was measuring about 18 millimeter in the longest axis. So this is the coronal view, and here you can see these 2 lymph nodes in the interaortocaval window. So what could this lesion be, and what are the options now? Dr. Imran?
Yeah, so I'm a little bit surprised that the chemotherapy was given like this without the raised tumor markers. Because one thing I'm always worried about also in these patients is that what if it is not really non-seminomatous germ cell tumor recurrence? It is some, just very rarely it happens, but what if it is tuberculosis or something like that? So I would have preferred the lymph node dissection or biopsy or something like that before giving the chemotherapy, especially 3 or 4 cycles of chemotherapy. That a lot of chemotherapy was given without the confirmatory diagnosis, and it's not up to the patient to decide that he want to have chemotherapy. I mean, because it is the physician's job to tell him that what is the appropriate treatment, and I will not give him chemotherapy even if he wanted to 4 years ago. So that's the problem over here, and now this patient needs definitely some surgical intervention or at least a biopsy and removal of the lymph node to see what's going on over there.
Right. So, Dr. Imran, that's what the case. So it was rediscussed in tumor board meeting and then decided to proceed with retroperitoneal lymph node dissection. And as Dr. Khurram has mentioned, that this is a kind of a morbid procedure with all the short-term and long-term complications. So the short-term complications like risk of prolonged ileus, damage to major vessels, potential risk of injury to the kidney as well as the renal artery and vein, renal hilum, and injury to bowel, as well as long-term complications like infertility, retrograde ejaculation was explained. And because he's a young gentleman, so we went for modified or template-based Rplnd. And final histopathology showed that this was a lymphoid tissue with multiple cystic spaces, and multiple nodules of immature cartilage was identified in the final histopathological specimen, consistent with immature teratoma. On the subsequent follow-up visits done by oncologists, his tumor markers were all normalized. Intervals, CT scan, chest, abdomen, and pelvis were all normal with no evidence of disease progression. And the last CT scan, chest, abdomen, and pelvis, and chest X-ray was normal. And it was decided that we need to follow him up subsequently. This is his chest X-ray, which is essentially normal. And these are the scans post Rplnd, the latest ones. And here you can see the surgical clips in the pre-aortic and inter-aortocaval window. And only the surgical clips are there. This is the modified template, starting from the level of renal hilum, going on the ipsilateral side up to the level of bifurcation of the common iliac vessels. And there is no evidence of disease in this particular case.
Nazim, I would like to just point to one thing here about the biopsy, which was suggested. Now, in this, this is a potentially curable kind of, stage still of testicular cancer. Now, if we biopsy or we do an inadequate, sampling, and the patient has in-field recurrence, it will be very difficult for anyone to go in surgically and resect the mass second time around. So your first chance is your best chance. So in that case, you want to do a full RPNLD and not face with in-field recurrence of the lesion, be it teratoma or some non-seminomatous. So that is the reason why biopsy is discouraged, or enucleation of that lymph nodal mass only is discouraged. Of course, there's going to be a situation when your surgical assessment based on the imaging will be that this is unresectable lesion, and now in those unresectable lesions, yes, you will do a biopsy, or biopsy may be justified to assist in the choice of chemotherapy and further treatment. But if you can resect it, you should resect it, and you should do a full kind of RPND so as to avoid the chances of an in-field recurrence, which is kind of almost impossible to treat surgically.
Thank you, Dr. Khurram. Very valid point. So I will move on to case number 3. This is a 22-year-old gentleman, single, and he came to our emergency department with complaint of abdominal pain central abdominal pain, which was radiating to back. And apart from this, he had history of weight loss of about 4 kgs in 1 month. He denied any other significant symptoms. His past medical and surgical history was positive for tuberculosis about 2 years back, which was treated with anti-tuberculous therapy. So on examination, his genitalia was normal with normal palpable testes, and abdominal examination revealed a vague, well circumscribed, about 10 centimeter mass in the upper abdomen on deep palpation. His workup from ER revealed a hemoglobin of 14 with normal TLC count. His creatinine was normal, and he had a CT scan chest, abdomen, and pelvis done from emergency room. So this is the CT scan chest lung window, and it shows some fibrotic changes in the apical zone on the right side, consistent with prior history of tuberculosis. The rest of the chest was normal. Again, no nodules in the lungs or in the pleura, no hilar or mediastinal lymphadenopathy, no consolidation, no pleural effusion. And this is the upper cuts of abdomen. And here you can see a heterogeneously enhancing lesion in the upper abdomen in the para-aortic area, and which is displacing kidney a bit. This is further image, and here you can see the mass is almost inseparable. It is inseparable from the psoas muscle, and it is also closely abutting the renal hilar vessels. So the size of this mass was around 9 centimeter by 7 centimeter. And lower down, there was no other lymphadenopathy. So these are the coronal images, and you can see this mass over here, which is very in close proximity to the renal hilum. And it is also abutting the aorta and was inseparable radiologically from the psoas muscle. So the patient was admitted under care of oncology from ER, and he underwent a needle biopsy of this mass, which showed a non-seminomatous germ cell tumor, yolk sac tumor, and had a tumor marker done, which showed raised levels of alpha fetoprotein more than 3,000 with normal beta HCG and raised LDH. Ultrasound, which was, the testes were clinically normal. However, an ultrasound of testis was done. And this is the cross-sectional ultrasound of left testis, and it showed a small, about 8 millimeter mixed echogenicity lesion in the testis, which showed vascularity on the Doppler. This is the longitudinal view. And again, this is the lesion in the left testis along with some testicular microlithiasis surrounding this lesion. The right testis was normal on the ultrasound. So this is the comparison of right testis. This is normal right testis versus the left testis. So to summarize it, it is an N3 disease, a nodal disease, a yolk sac component, N3 because the size was more than 5 centimeter, alpha fetoprotein was more than 3,000, which categorizes it in the S2 range. So this was an stage 2 S2 non-seminomatous germ cell tumor. And according to the International Germ Cell Cancer Collaborative Group, IGCCG classification, this is an intermediate risk because of the because there was no non-pulmonary visceral metastasis and the tumor markers were S2. So question to the oncologist and radiation oncologist and Dr. Khurram. So what are the options in this case?
Let the medical oncologist take the lead on this. Yeah.
So I think, this 8 millimeter lesion, I'm not sure if this is primary testicular germ cell tumor, or it is a primary retroperitoneal germ cell tumor. So looks like that it might be actually primary retroperitoneal germ cell tumor. And since the tumor markers are high, I will start him with the chemotherapy immediately. And after giving 3 or 4 cycles of BEP chemotherapy, I will restage him. If he has complete response in the retroperitoneum and the testicular lesion is still there and suspicious, then I will consider orchiectomy on that side only. Now, if the after the giving the chemotherapy, the lesion in the retroperitoneum is still more than 1 centimeter in size, then I will request my surgical colleague to consider lymph node dissection along with the left orchiectomy in this patient.
Thank you, Dr. Imran. So considering the prior history of anti-tuberculous therapy, so what are the risks of the classic bleomycin erythropoiesis cisplatin? Would you go for the classic BEP chemotherapy in this gentleman? He had some lung fibrosis.
Right. So he has some lung fibrosis. Usually TB causes apical lung fibrosis and doesn't cause, diffuse interstitial fibrosis or anything that can preclude. So I will do a DLCO definitely. And if the DLCO is normal, I'm assuming it will be normal in this young patient. I will, and since he has no no pulmonary mets, that he might need the surgical resection in the future, I would consider giving him bleomycin if his DLCO is normal.
Right, so his workups were done with pulmonary function test, spirometry, DLCO, echocardiography, and 24 hours creatinine clearance, and all these tests were normal. So he underwent 4 cycles of BEP. And following that, his CT scan, chest, abdomen, and pelvis, ultrasound, testis, and tumor markers were done. The tumor markers were all came down to normal. And ultrasound showed that there was evidence of microlithiasis in the left testis. There was a well-defined hypoechoic lesion, which was previously around 8.5 millimeter, which was reduced to around 6.2 millimeter with some focal calcification. The right testis was normal.
And the CT abdomen showed what?
So, am I audible?
Yes, you are.
I'm having trouble moving the slides a bit. Sorry,
yes. So Dr. Nadir, what was the CT finding at this point?
So the CT, I'm going to share the CT scan, but somehow my computer is stuck.
Meanwhile, while you're sorting out the computer issue, Nazim, can I request Dr. Imran to please explain to our residents what is DLCO and how does it help in deciding the use of a chemotherapeutic agent?
Right. So usually we request a pulmonary function test, but if you just request a general pulmonary function test, they might not include DLCO, which is a diffuse lung capacity. And basically, bleomycin causes interstitial fibrosis. So any kind of fibrosis, either it happens with the bleomycin or in the autoimmune disease or anything which affects the alveolar septa, causes the diffuse decreased capacity for the diffusion of the gases. So this is very important to do a DLCO test along with the pulmonary function test to see how the diffusing capacity of the gases are. And if these are normal, then probably you can proceed with the bleomycin, because bleomycin toxicity is mainly at the diffusing capacity level. So that's what the DLCO test is. And if it is normal, then it is usually safe to give bleomycin. Now, remember that DLCO is not the only thing. Also, the underlying, lung diseases can preclude the use of bleomycin. And if there are multiple pulmonary metastasis in which patient you are suspecting that the patient might need lung surgeries in the future for non-seminoma, residual disease, some people avoid bleomycin in those patients also, because patient might end up intubated and prolonged intubation if you have used the bleomycin in the primary setting.
Thank you very much. I think that's very helpful for the surgical residents to understand this concept. Nazim, are you okay to proceed?
So am I audible, sir?
Yes, you are now.
Right. So I'm trying to just share it again. No, that's stuck again. Something is going wrong. Okay. Can I ask Sharif to unshare my screen? I will try to connect it with my desktop. It's open on my desktop as well. Just a moment, please.
For the audience, please feel free to write your question in the chat box. You're almost at the end of this presentation. So related to any aspect of testicular cancer, if you have questions, please feel free to write and we will ask our panel to address those questions.
Right. So sorry for this delay. So this gentleman completed 4 cycles of bleomycin, etoposide, and cisplatin, and the CT scan, chest, abdomen, pelvis, ultrasound were done. And right. So we were over here. Yeah. So the CT scan showed that there was interval reduction in the size of this large mass. And here you can see, you can now identify some plane between the aorta and the psoas muscle. And the size, which was previously around 9 centimeter, it reduced to about 4.2 centimeters. And these are the coronal images where you can see the mass which has shrunken. So CT scan showed interval decrease in the size of left para-aortic lymph node about 50% with normalization of tumor markers. So the case was again discussed in tumor board. What are the options now?
So I will request Dr. Khurram to comment, but suppose if the tumor markers were not normalized, then I would not consider surgery in this patient and I will go with the salvage chemotherapy, second round of chemotherapy with another agents. But since the markers are normalized, I will refer patient to our urology colleagues.
I totally agree with Dr. Bilal on this. I think we can move on. Yeah, RPNLD is.
So this gentleman underwent left radical orchidectomy as well as RPLND, and there was no palpable lesion on the left side of testis, and we found a 5 into 4 centimeter mass, which was lateral to the aorta, and it was adherent to peritoneum anteriorly, aorta medially, and kidney and ureter superolaterally. And we found that there was some necrotic component, and this lymph nodal mass was densely adherent to the surrounding tissue. So the histopathology showed it to be a necrotic tissue with no viable malignant cells and no malignant germ cell tumor in the specimen. So upon his last follow-up, he's doing well. His tumor markers are all normal. This is the CT scan, chest, abdomen, and pelvis, and these are the surgical clips you can see. And the mass is completely removed, and there is no evidence of any retroperitoneal or pelvic or inguinal lymphadenopathy on the subsequent surveillance. So since I have just few minutes, so this is just a brief and interesting case, which is case number 4. And this patient got LAMA, but this is we could not manage him over here in this hospital. But this is a 52-year-old gentleman with no known comorbid, a resident of Afghanistan, presented to ER with history of cough for last 2 months, which was productive in nature. He also had left-sided scrotal swelling for past 2 months. And along with that, he had abdominal as well as back pain and history of weight loss of about 7 kgs in about 2 months. He denied any history of fever or any other constitutional symptoms. And on examination, the abdomen was soft, it was non-tender. The left testis was hard, and it was enlarged about 10 by 7 centimeter in size. The left spermatic cord was thickened with mass extending up to the left groin region. The right testis was normal, and the chest showed decreased air entry bilaterally. His lab investigations from ER showed a normal CBC, urine DR. His sodium was a bit low, his creatinine was normal. However, his tumor markers showed a raised LDH of about near about 2000. His LFTs were normal, and his alpha fetoprotein was again fairly high. It was around 13,000 international units per ml, and beta HCG was around 7,000 milli-international units per ml. So this is the chest X-ray of this 52-year-old gentleman, which was done from ER. And what it shows is it shows multiple radio-dense nodules scattered throughout the lung field, consistent with the cannonball appearance. And this is the imaging of left-sided, this is the image of the left testis, which showed that the left testis was replaced by an irregular mixed echogenicity tumor, which showed vascularity on Doppler. These are the scans of these are the CT scan images, which showed again multiple nodules in the scattered throughout the lung fields, as well as the pretracheal and paratracheal and hilar lymph nodes. This is the CT scan abdomen, which showed a conglomerate of mass, which is encasing the great vessels, the aorta and inferior vena cava, and measuring about 9 by 5 centimeters in the greatest dimension. So this is a 52-year-old gentleman presenting with shortness of breath, abdominal and low back pain, as well as left-sided testicular mass. And the workup showed all 3 tumor markers to be raised in the S3 range, with multiple lung nodules, a large retroperitoneal lymph node, and left-sided testicular enlargement. So the question to Dr. Imran, how should we go about this particular case?
All right, so this is a fairly advanced stage non-seminomatous germ cell tumor. I will start him with the chemotherapy first. After the inguinal orchiectomy done. So we still need, if we have enough time, I mean, I don't know how symptomatic he was, but if we can tolerate to have left inguinal orchiectomy and the diagnosis is done, then start immediately on the second day of surgery with the chemotherapy first. Once the chemotherapy is done, then if the tumor markers gets normalized, then we have to see that what happens with the abdominal lymph nodes and the chest lesions, and we have to really work out with urology and with the chest surgeon to see which lesion needs to be resected and you know how and things like that. But first we will start with the chemotherapy and immediately after the inguinal orchiectomy.
Okay, there is one question about the last case that was presented, and I'll put it to Dr. Imran Ahmed, that in the last case, when after the chemotherapy, the tumor markers normalized, but on the CT scan, we have one lesion which subsequently proved to be a non-cancerous lesion with no malignant cells. Would the PET scan be of any help at that point?
No, for the non-seminomatous germ cell tumor, doing the PET scan might give you wrong information. So, you know, for example, if it is teratoma, you might still need the surgery, but the PET scan would be negative in case of mature teratoma. So I don't think that we should encourage people to do the PET scan in non-seminomatous germ cell tumor for evaluation of lymph node, because the decision doesn't based on the PET scan. But in cases of seminoma, yes, PET scan is very sensitive, and actually our decision to do surgery or further chemotherapy or radiation depends on the PET scan, but not in non-seminomatous germ cell tumor.
Great, thank you very much, and I'm really grateful to the presenter, Dr. Nazim, to our august faculty, Dr. Khurram Siddiqui, joining from Sultan Qaboos, Dr. Imran Ahmed and Dr. Bilal for their presence and very valuable comments. I hope they have clarified some of the confusion that exists in the mind of some of our residents about when to do chemo, when to operate, and how to investigate patients. So thank you very much for the panel for this very valuable session. And I think we had a brilliant start of this course. We move on to the next presentation. I'm really grateful to Dr. Zishanuddin, who is our dedicated uropathologist, and he's a regular member of our MDT meetings, the tumor board meetings, provide very valuable information for decision-making in urological malignancies. So Dr. Zishan is going to address some of the key points of interpretation of uropathology reports. And please feel free to ask questions, because interpretation of uropathology report, the urological malignancy reports, as well as is as important as that, or even probably more than the uroradiology. So Dr. Zishan, the floor is yours. Please.
Okay, thank you very much, Dr. Hammad, for the kind introduction. Am I clearly audible to all of you?
Yes, you are.
Okay, let me share my screen with you. Okay. Okay. The topic which was given to me for this presentation is how to read and interpret a uropathology report. So it's kind of a long topic. We can have a long discussion on it, but I've tried my best to summarize things which are more relevant to you, to the urology residents. I will be, mainly focusing on the bladder tumors followed by prostate, little bit about kidney. Yeah, that's it. I'm not touching upon testes in my discussion because of the time constraints. So starting with the bladder tumors. What I have done is that I have taken examples from the real life, from my routine cases. And here I'm showing you a case of TURBT, which was, sent to me with this history of, non-smoker diagnosed with bladder growth. And the gross description tells you that, how many containers were received in the pathology lab. Here it says that there are 2 containers, right, in formalin, and giving in, specimen sent in formalin means that it was adequately fixed, and the person who sent, did the right job. Sometimes we do receive specimen without formalin, and we do mention here that it is without formalin. And in this case, you will expect that the tumor or the tissue will be autolyzed, and you won't be able to have a good, pathology report based on that. So this was sent in 2 containers. The first one was bladder growth, and the second one was a deep bladder biopsy. This is a routine in our practice. You all know we sample deep bladder biopsy separately. So coming to the microscopy, since I have been teaching you about the uropathology in the last few years, so this is the right time to, test you guys, the urology residents. So the microscopy shows that in the specimen number 1, there was these complex branching papillae covered by columnar to polygonal tumor cells, having abundant eosinophilic cytoplasm, mild nuclear polymorphism and hyperchromasia, and minimal loss of nuclear polarity with occasional mitosis. So tumor is not invading the lamina propria, and Muscularis propria and specimen number 2 is tumor free. So can anyone give me any suggestion that what kind of tumor we are looking at? Any trainee, urology trainee?
Please feel free to write in your chat box to the questions.
Okay, we have some answers here. Yeah, someone says papillary TCC, Hammad, and then some said pun lump, squamous cell carcinoma, TCC. Yeah, definitely it's a TCC. I'm talking about the, non-muscle invasive bladder cancer. Good answer. So this is something papillary. You can see the architecture is papillary, and there is mild nuclear polymorphism, minimal loss of polarity, and mitosis. So this is something, nothing high grade. A papillary tumor, which is kind of low grade in morphology, which is non-invasive. We have a differential of, low grade papillary urothelial carcinoma versus pun lump here with the description here. And let me show you the slides here. This is the complex papillae here, and there is loss of, polarity is there. It's minimal, but it is there. So this doesn't qualify for pun lump, right? So this is a low grade papillary urothelial carcinoma. And since in the list of the non-invasive urothelial neoplasm, this will best classify as non-invasive papillary urothelial carcinoma, low grade, because not high grade. Pun lump is kind of, very bland looking. It's not a papilloma. The thickness of epithelium is too much for that. And this is not a flat lesion. That's why we are not talking about urothelial dysplasia or UPUM. These are very rare entities. You don't have to worry about them. So this is a non-invasive low-grade papillary urothelial carcinoma, and this is how the pathology diagnosis would look like at the end. Non-invasive low-grade papillary urothelial carcinoma. We give the WHO ISUP classification at the end. This is what we follow here in our lab because we follow the CAP, College of American Pathologists guidelines here, and this uses this WHO ISUP system of classification in bladder cancer. And it is the most common system followed worldwide as well. Lamina propria is present and uninvolved by the tumor. So is there anything missing here in the pathology report? You must have, if you have seen it, the gross description, carefully, there was this mention of specimen number 2. Here it only talks about specimen number 1. So you have to be very careful. Sometimes pathologists can miss the second specimen to be mentioned in the diagnostic lines. It's there in the microscopy, but it was not mentioned in the diagnostic line. So you have to go back and ask the pathologist to comment on the Muscularis propria sent separately in the specimen number 2. So whenever we use Muscularis propria, we are talking about retrusor muscle, but the correct histological term is Muscularis propria. So this is what I use and most of the pathologists use in their pathology reports. Another case, another bladder growth. Here you can see it was sent in single container, again in formalin, and this was a 10 cm tissue, and representative sections were submitted. When we say representative sections, we have submitted some of the tumor, not all of it. So you have to be very careful with these, descriptive terms. The microscopy here, again, complex branching papillae. Here the nuclear atypia is marked memorphism in hyperchromasia, loss of polarity, frequent mitosis. There's something papillary again, but this is high grade. The cytology is that of a high grade. Tumor is not invading the lamina propria. Muscularis propria is not identified in the sections examined. This is the pathology report. So this is the histology, the microscope, the slides. You can see the papillae with the high-grade cytological atypia in the tumor cells. I can't see any lamina propria invasion in these slides. So this is a non-invasive high-grade papillary urothelial carcinoma. I don't see any muscle here in these slides. So this was the report, right? Non-invasive high-grade papillary urothelial carcinoma, same classification that I mentioned earlier. Lamina propria is present and uninvolved by the tumor. Muscularis propria is not identified. So is there any problem with this report? Can anyone tell me what's the problem with the report? Keeping in mind the gross description. No muscle. Yeah, that's kind of painful, No muscle. Yeah. So if I go back to the slides, the gross description, it says representative section submitted. So here the problem is that the pathologist has said that he didn't see the muscle without submitting additional sections, right? So this is a key here, representative section. If you see this, this is the, proper teaching is that I teach my trainee pathologists that they have to go back and submit more section to look for any muscle. So this was a problem here. This wasn't, sampled correctly. So in an ideal situation, the specimen should have been entirely submitted before calling something as muscle not identified, right? So this is the issue here. Okay, coming to another case. Here, the bladder growth was clinically non-invasive, TA disease. And here the tumor was, the tissue was entirely submitted. That's good. This is the histology. Again, complex papillae. And the cytology is also high grade. Cells have prominent nuclei, loss of polarity, abundant mitosis. But here the tumor is focally and superficially invading the lamina propria. And Muscularis propria is there, but it's tumor free. So a clinically non-invasive tumor is showing lamina propria invasion. This can happen, lamina propria invasion is can be really focal, superficial, and may not be clinically evident. So this is the slide. You can see the non-invasive part on the left side, and on the right side, you can see the lamina propria invasion. So
Zishan, can you identify the lamina propria by your marker? This is one of the
yeah,
residents who'd like to.
okay. So here you can see a nice alignment. The base of the epithelium has this line, this is called the basement membrane, right? And this is the epithelium on the left side. And this loose tissue, which is kind of, um, some spindly cells, some inflammatory cells, this is lamina propria. And this large aggregate of cell, which I'm pointing you right now, this is all the tumor which is lying in the lamina propria. What happens as soon as the tumor invades the lamina propria, the cells become larger, they become more pink. We call it paradoxical eosinophilia. So this is a sign of, lamina propria invasion. Some people are most of the experts are very strict about the lamina propria invasion histological criteria. So yeah, but this is a very classic example of lamina propria invasion. So this kind of loose tissue in the subepithelium, which is lamina propria.
You also use the term loss of polarity. Can you explain this a little further before you go to the next
Yeah,
case, please?
yeah. If you look at the first case, the previous case here, uh, here, this is a papilla, and the nuclei are kind of, radially arranged. They're pointing towards the surface. So they have these, polarized, they all are aligned in the same direction, right? And this is a low-grade tumor. And if I go to the next case, which was high grade, here there is no polarity. Like they are like the haphazardly arranged. Some are large, some are pointing towards one direction, some are pointing towards other direction. This is loss of polarity. And as I move here, you can see this is all again the loss of polarity in all this tumor. This is high grade cytology. And here again, you can see the epithelium on the top, on the right corner, and this loose tissue is kind of, with pink spindly cells. This is lamina propria, and in this huge bundle, organized smooth muscle bundle, this is muscularis propria. So the muscularis propria in this case was tumor-free. So this is an invasive high-grade papillary urothelial carcinoma. Now we are coming to invasive tumors. This is an invasive high-grade papillary urothelial carcinoma. And when we see lamina propria invasion in isolation, recommendation is to quantify it, whether it's like superficial or multifocal, focal or multifocal, superficial or deep. This is the recommendation. Currently, the staging system that we follow says PT1 to these diseases which have lamina propria invasion. But in the future, you might have this subcategorization of this PT1 disease into 1A and 1B based on the depth of lamina propria invasion. Currently, it's not done because it's kind of very difficult to assess, especially on a TURBT. But we always try to quantify in a descriptive fashion. Like in this case, we said that this is a focal superficial invasion of the lamina propria. And muscularis propria was clear in this case, so this is a T1 disease. Coming to another case, this was a clinically muscle invasive disease. Again, quite a lot of tissue, 4 cm, entirely submitted. That's good. So this is an invasive tumor to start with. The description says with mostly aggregates and with focal papillae. There's something invasive, predominantly invasive going on in here with a high grade cytology, marked nuclear polymorphism, frequent mitosis. Tumor is extensively invading the lamina propria, which is like, the extensive is telling you that's quite a lot of lamina propria invasion, and muscularis propria is involved by the tumor. This is a slide of this case. This is a tumor, very high grade cytology. And on the right side, you can see these big pink bundles of smooth muscle fibers. This is muscularis propria. Tumor is going in between that. So this is a clearly invasive kind of, urothelial carcinoma. Again, a muscularis propria invasion. You can see these pink bundles, light pink bundle, and this blue are the tumor cells going in between the muscle bundles. So this is when we call something as invasive high-grade urothelial carcinoma. I didn't say papillary here because the tumor is largely solid, non-papillary. Lamina propria is extensively involved. Muscle is present and involved by the tumor. This is a T2 stage. In most cases, we don't give a pathological stage on a TURBT. It is not recommended. But sometimes, if it is requested, we can do it. But the current CAP recommendation is not to stage TURBT case. Then another scenario in which a patient was with a known high-grade bladder cancer, non-invasive, and suspicious area on check cystoscopy. And usually in this case, scenario, a small chunk of tissue is sent like 0.5 cm here, which was entirely submitted. And again, here there is no papillae. There is a urothelium covered fibromuscular tissue, and the urothelium is of normal thickness with focal denudation. But there is marked hyperchromasia of the nuclei, polymorphism, and frequent mitosis. Something flat, a flat lesion is there. The urothelium is flat with marked atypia. There is no papilla formation or invasion. Muscle is also unremarkable. This is the slide. You can see the loss of polarity in the flat urothelium. There is no papilla formation. Frequent mitosis, I am pointing the mitosis here. So this tells you this is the flat lesion with a high-grade cytology, and this is what we call carcinoma in situ. And this we commonly see this especially in a radical cystectomy case, and also in a follow-up cases of this kind. Okay, this was carcinoma in situ. And the carcinoma in situ is by definition non-invasive. So we don't have to tell about the lamina propria or muscle invasion, but sometimes we do mention it separately in the pathology report. So these are the 4 lesions scenarios I talked about. I talked about a papillary, non-invasive. Then I talked about a papillary invasive cancer. Then I talked about a flat, mostly solid invasive urothelial carcinoma. And then in the end, I talked about the CIS, carcinoma in situ. Then coming to the pathological assessment of muscularis propria, which can be problematic, for us, and it can raise arguments between the clinician and the pathologist. It's not always straightforward. There are a lot of histological mimickers of the muscularis propria. So just for the pathologist, muscularis mucosae can look like a muscularis propria. Sometimes it's so hypertrophic, it can look like muscularis propria. And sometimes the carcinoma can induce a reaction in the stroma, which looks like muscle. Or sometimes the glands, the urothelial glands, urothelial carcinoma colonize the prostatic glands, and the prostatic stroma can look like muscularis propria. So these are, and the tangentially cut vessel in the lamina propria can also look like muscle. These are the problematic things a pathologist has to keep in mind while assessing the tumor to call something as muscle invasive or not invasive. So there are very strict criteria. You don't have to go through this. These are the strict criteria for pathologists to call something as muscle invasive. So luckily, most cases can be pathologically classified into invasive versus non-invasive, or lamina propria versus muscularis propria invasion. In most cases, we are able to classify. And these can be achieved by keeping in mind the anatomical landmark by the pathologist, additional sampling by the pathologist, deeper levels. As I told you, the pathology block is like 5 millimeter thick. So you can always have some more, diagnostic tissue in the deeper levels. So we always do that. But you can always come across such cases in which it's very difficult whether these pink bundles are muscularis propria or muscularis mucosae. They are very prominent. I sometimes can, I'm tempting to call this as muscularis propria, but hypertrophic muscularis mucosae can look the same. So we come across these kind of situations, not very frequent, but sometimes. So in such a case, we diagnose it as invasive high-grade urothelial carcinoma with extensive lamina propria invasion, and we write a big note here. And this says that invasive urothelial carcinoma, at least the lamina propria, there is infiltration of smooth muscle, but histological features do not allow distinction of muscularis mucosae from muscularis propria in this biopsy specimen. Correlation with the clinical finding is required. Additional transurethral sampling and/or imaging to assess the muscularis propria is suggested. So you may come across such a pathology report in your practice. So then we have a scenario in which some of the clinically obvious muscle invasive tumor may turn out to be lamina propria invasive only, and the pathology report will say that there is no muscle there. So how is it possible? it may look like this: no definitive muscularis propria present to assess in vision. How is it possible? The radiology is saying that the lesion is T3 and there is no muscle in the pathology. So what's the reason? So this can happen, and the slide will look like this in such a case. All tumor, no normal tissue in between. The tumor has replaced the entire tissue so much that we are unable to see any residual muscle. So this can raise a huge argument between the clinician and the pathologist sometime. And the possible reasons that I told you: muscle may not be sampled by the pathologist. The pathologist may have not submitted the tissue entirely, as I showed you in the previous example. So here always, it is advised to go back to the specimen and submit more tissue. Deeper levels can, ease the problem. Interpretation error can be there because of the lack of expertise by the pathologist, and the muscle might be missed on the slide. It was there, but it wasn't picked up by the pathologist. And poor preparation by the of the slide and staining. This can happen in the pathology which is read in a small lab from the remote centers. So this can also be an issue. Then the more common one is the extensively invasive tumor replacing all the muscle in the biopsy. This is a more common reason which I usually encounter in my practice. That is, tumor is so much so that it has replaced all the tissue and I can't see the muscle. So I cannot call something as muscle or not. So in this case, clinical radiological correlation is required. You don't like this line, but sometimes you have to use it. And then the last, scenario, muscle may not be sampled by the surgeon. So here the responsibility lies on the urologist. Sometimes it happens that the muscle is not sampled during the procedure. So then a few words about the aggressive variants of the urothelial carcinoma you should keep in mind while interpreting a pathology report. Most of the cases are the usual kind of the urothelial carcinoma. So we don't use the usual word, we call it urothelial carcinoma. TCC is an obsolete term. We don't use TCC anymore. If you want to use UCC, that's okay, but don't use TCC. So among the aggressive variants, the urothelial carcinoma with divergent differentiation is there. That it is defined as a tumor which has some percentage of the usual type, and there is also the presence of some other morphologies, and these morphologies are usually like they have a high grade and locally advanced tumors. Squamous differentiation is the most common, which is seen up to 40% of the invasive tumors, followed by glandular. And literature says that they both of these differentiations, squamous and glandular, have a poorer response to chemotherapy. So you should keep in mind. And we try to give a percentage of this differentiation. We say urothelial carcinoma with focal glandular differentiation or extensive glandular differentiation, or some people give the percentage of the glandular differentiation in their reports. Then we also can have the small cell or large cell neuroendocrine differentiation, which is a kind of a very aggressive tumor. Then uncommon is trophoblastic differentiation. Then we have certain variants of the urothelial carcinoma. The nested variant, including the large nested variant, is very aggressive. It is very deceptively bland looking nuclei. That's why we don't grade this tumor. This is by definition high grade. Micropapillary variant, as we have seen some cases in our tumor board as well, it can be mixed, it can be pure. And some people say that the radical cystectomy in a micropapillary variant can be of value, even in the early stage cases. And plasma cytoid or signet ring or diffuse variant, another uncommon, but we have seen a few cases in our in-house cases. Then sarcomatoid variant is also aggressive. So I'm talking about the glandular kind of tumors that we have seen a few cases in the tumor board in which there was this glandular morphology in the bladder tumor. So we all know that the bladder has originated from the hindgut. That's why the features of the adenocarcinoma in the bladder are very much identical to the colonic adenocarcinoma, and they have an identical immunoprofile as well. So immunostic chemistry is of very limited value. There are some stain which can help, but not always. So clinical input is very important. Radiologically, we have to see, and if we don't have any clinical information available, so we write a note in a pathology report. We say that this is an adenocarcinoma, whatever differentiated, like well to moderately differentiated. And we say direct extension or metastasis from another organ should be ruled out clinically before considering it as primary of bladder. So this is a case. And then in this, the staging system by AJCC 8th edition that we follow in our radical cystectomy cases. You all know this. So I'll go through this and briefly about the immunohistochemistry. Sometimes we do mention immunohistochemistry in our report. Most of the cases, luckily in the bladder, they don't require any immunohistochemistry. I usually don't perform immunohistochemistry in my bladder cancers, but there are some scenarios where I use them, like when I am not sure whether this is a primary urothelial carcinoma or it is coming from the adjacent organs. Like there is a common scenario that there is a polydifferentiated tumor involving the bladder, and it can turn out to be of prostatic origin if you apply immunohistochemistry. And also cervical squamous cell carcinoma can also look like urothelial carcinoma. I've seen a few cases. So in these scenarios, immunohistochemistry can be used. Then glandular tumors, as I told you, in this scenario, immunohistochemistry can be used, but in my experience, it is of limited value. Also, CIS can be confirmed by immunohistochemistry. People do it. I usually do not do it, but in the literature said that these immunostains can be helpful. And in the radical cystectomy, I perform immunohistochemistry just to be sure about the extent of the disease in the before staging or any subtle lymph node metastasis, calling something as N1 or N2. So, and these are the immunostains which are usually positive in bladder cancer. Of course, it is an epithelial malignancy. It should be positive for pancytokeratin or AE1, AE3. CK7 is mostly present in bladder. CK20, another cytokeratin, it is present in 70% of bladder cancer. GATA3, although a very popular marker, but it can be very non-specific. You have to use it in the right context. Similarly, P63, and these stains can also be helpful in a metastatic setup, where when there is no known primary, or whether it's there known primary in the bladder, and we want to confirm it is the same tumor coming to the lymph node or other metastatic site, so we can apply these immunomarkers. So their role is to support the morphological diagnosis. You cannot trust them blindly, and they should be relied upon only in the right context. So that's the message here about immunohistochemistry. So coming to the prostate, a usual case of BPH has this. We usually receive these prostatic chips, and just to remind you again that if the tissue of the prostatic chips is around 12 grams, we submit it entirely. So 12 gram of tissue is submitted entirely, and for any additional tissue, one cassette is made from any additional 5 grams. For example, if we receive 17 gram of the chips, 12 gram will go directly entirely submitted, and the remaining 5 out of the remaining 5 gram, we will submit only one more cassette. This is how we do. This is how we sample. And this is a classic histological appearance of a BPH, dilated glands, double layer of epithelium, and some glands show corpora malacia, although it is not very specific for benign NC. You can also see corpora malacia in the tumors, and some of the fragments also show proliferation of the stromal cells. So this is how it looks like under microscope. The gland lined by double layer of cells, the stromal cells here. This is what we call benign glandular and stromal hyperplasia of prostate, or BPH. This is how the reports looks like. Another case of BPH with prostatic chips, clinically BPH, but prostatic chips. Here again, the tissue was entirely submitted because it is under 12 gram. And here you can see description says small size closely packed glands lined by single layer of epithelial cells. Single layer of epithelium, closely packed gland, that raises the alarm, and prominent nuclei. So this is a sign, as you might remember from my lectures, that this is a sign of malignancy in prostate. Nuclear hyperchromasia, plymorphism, mitosis, this doesn't apply here. This was in the bladder. But in the prostate, the glands become small, crowded, lined by a single layer of epithelium. Still, they are very bland looking. There is not much plymorphism here. You can see very bland looking nuclei, but they are lined by a single layer of cells. The glands are single layered. occasional nuclei here and there, but this is malignant. This is the case of prostatic adenocarcinoma. And since these are the well-formed glands, this will qualify for Gleason pattern 3. So this is how the report looks like, adenocarcinoma prostate. So when I say NOS or SNR type means the usual type. Some people stop at adenocarcinoma, don't say NOS or SNR type. It also means the same, that they are talking about the usual type adenocarcinoma, because there are some uncommon types of prostatic cancer like the ductal type that you can see in your practice. So for distinction from those tumors, I usually use the term NOS or SNR in my reports. So the Gleason, since this tumor was purely of one pattern, so we know that the Gleason score is doubled if you see only one pattern. We saw pattern 3, so we call it Gleason major 3, minor 3, and we call it sum of 6. And now since a few years we have been using this prognostic grade group, because we know that the pattern 2 and pattern 1, they are not used in the biopsies. In the TURP or in the trust biopsy, we don't give the pattern 2 or pattern 1 because they cannot be diagnosed on a biopsy. They need to have the low power architectural view in mind, which is only possible to be appreciated in a radical prostatectomy. That's why pattern 2 and pattern 3 are not given on a prostatic biopsy or not on a TURP. So the prognostic grade group is added just to tell you that this is the lowest possible grade in a biopsy or TURP. So this is the the lowest possible, that is 6. And then we always quantify the tumor, that how much tissue is involved by the tumor, and perineal invasion is there or not, when you know that's the sign of the aggressive behavior. And then coming to the trust guided biopsy, 12-core trust guided biopsy. This is one of the longest histopathology report we usually come across. And it's because all these 12 cores are submitted separately. They have their separate gross descriptions and the separate microscopic descriptions. This is the protocol that we have to follow, that all specimens should be, you know, given the microscopic description separately, or their diagnosis is given separately. So all these, have their, uh, for example, if I pick the container number 6, this says prostatic adenocarcinoma, Gleason major 4, minor 3, sum 7. Then I give the prognostic grade group, perineural invasion not identified. And some labs, they do give a summarized report at the end. Currently CAP doesn't, makes it mandatory. So we don't use it here. We give each core a separate diagnosis in our pathology report, all these 12 cores. So I just took one of the cores, and it shows, these fused cribriform gland lined by a single layer of epithelial cells. So when I say fused cribriform glands, you should recall from the Gleason pattern, the fused cribriform glands qualify for pattern 4, and prominent nuclei again there. Focal well-formed gland also there, which is a description of pattern 3. So this is how it looks like on slide. This whole focus with huge, large gland which have these sieve-like pattern, which is called scribriforming. This is indicative of pattern 4. And this small focus over here of well-differentiated glands, this is pattern 3. So this is a pattern adenocarcinoma 4+3. So in a case of a pattern 7, sum 7 or more, the CAP, the College of American Pathologists, recommends to use the percentage of pattern 4. Here I've used the percentage of pattern 4. It is more than 75%, because some studies have suggested that if the percentage of pattern 4 is low, then those, for example, in the case of 3+4 tumor, and the percentage of pattern 4 is around 10%, then those cases, those patients can be followed up with the surveillance only. This is some of the studies which suggest this. Also, if the percentage of pattern 4 is 75% or more, these patient can do as bad as pattern 5. So the prognostic grade groups, just to remind you, these are the 5 groups that we use. And talking about tertiary pattern, this is only used for the radical prostatectomy specimen. And this is a pattern which is of higher grade, but it is occupying less than 5% of the whole tumor. So that's why if you see, for example, if you see pattern 4 and 3, uh, the major is 4, minor is 3, but there is a pattern 5 which is occupying less than 5% of the entire tumor in a radical prostatectomy. So in this scenario, we'll give 3 patterns: primary 4, secondary 3, and a tertiary pattern 5. So the tertiary pattern is a higher grade in a radical prostatectomy, which is occupying less than 5% of the entire tumor. Also, there is a issue about the agreement between the Gleason score between biopsy and radical prostatectomy, and this agreement based on different studies is about 70%. So there is a 30% chance that the grade may not be similar. If whatever grade given on the biopsy may not be similar on the radical prostatectomy, and the reason being it's a sampling error on a biopsy. Biopsy cannot represent the entire prostate. Also, there is a chance of undergrading on a biopsy because the pathologist is unable to see the borders of the tumor on a core biopsy. So they might call something which is actually 4, and it may get misinterpreted as pattern 3 on a biopsy. And talking about a few words about the variants that you might come across in your pathology report, very kind of uncommon. So these 4 types, atrophic, pseudohyperplastic, microcystic, foamy gland, they are kind of similar to the usual kind of adenocarcinoma. Then we have a mucinous variant, which has a better prognosis. The signet ring-like, very aggressive. I've never seen a case of signet ring-like. Pleomorphic giant cell, sarcomatoid, and large cell neuroendocrine, small cell neuroendocrine, we see this commonly, and they are very aggressive. And sometimes they are mixed with the normal SNR pattern. Then a few words about the ductal adenocarcinoma. I talked about it previously. They are uncommon. They are mostly periurethral. That's why I call urinary tract symptoms. The PSA levels may not be as high as an SNR adenocarcinoma, and they are aggressive tumors. And they can be diagnosed early due to the transurethral location, and most of them, they qualify for Gleason pattern 4. So they are aggressive tumor. You should keep this in mind. This is how it looks like. The large, glands, columnar epithelium, just like the colonic type of epithelium. So few words about the immunostic chemistry in the prostate. It is required in cases of when we want to confirm that the gland is lined by single layer or double layer, because single layer is a sign of malignancy. To check the loss of basal layer, we can perform immunostic chemistry. We have these 3 strains available in our lab: 34 beta 12, P63, and CK56. MCR is a stain which expressed in the tumor. ERG is also expressed in the tumor, not in the benign glands. And sometimes we use immunohistochemistry when we want to differentiate prostate versus urothelial carcinoma. Briefly, kidney tumors, this is the classification that we follow. So these are the common ones: clear cell and papillary, chromophobe, oncocytoma, which is a benign tumor. And there are some uncommon ones. So this is again the classification here. And then we also come across these translocation tumors, renal cell carcinoma. This is a grading system called WHO ISUP nucleolar grading system. The Furman grading system is not used anymore. It's obsolete. This is a new system that we follow in all our pathology report. It's quite a lot of similarity between this and the Furman system. Again, this is a 4-tier grading system. And just to tell you that the rhabdoid and the sarcomatoid differentiation, whenever is there in a tumor, it qualifies for grade 4 directly. So whenever we see rhabdoid features or sarcomatoid features in a typical clear cell RCD, it jumps to grade 4. And this is a staging system that we follow for the renal tumors. And just to briefly talk about the immunochemical profile of the renal tumors, they are negative for both cytokeratin 7 and 20. And this can be a helpful feature when we want to know, when we are looking at a tumor at a metastatic site. Other than histology, of course, the clear cell features, these immuno can also help. And PAC-SIT is another marker which is relatively specific for kidney. And we have carbonic anhydrase 9, RCC, and CD10 as well. So with this, I stop. And if there are any questions, I am happy to answer.
Thank you, Dr. Zishan. I think it was a wonderful presentation. There are a lot of questions that you have already addressed, and I've been looking at the chat box. So most of the things that you have really already answered in your subsequent slides. And these are some of the weak areas for majority of the residents where the interaction with pathology and with the clinician is not as close as it is perhaps in this hospital and some of the other hospitals. So we are really grateful for this wonderful presentation, and I'm sure that our resident must have benefited a lot. So thank you very much, and we move on to the next talk.
Thank you very much.
So for the next talk, I'm going to focus on renal cell carcinoma, and just to start my presentation, just give me a second. Okay. Is my screen visible to all?
Yes, sir.
Okay, great. I'm really grateful to Dr. Zishan Aslam, who is a consultant urologist at in Dundee, in Nine Wells Hospital. Sorry, not Nine Wells, at Dundee. Zishan is extremely helpful in our endeavor to develop laparoscopic services in Pakistan. And he's a co-moderator in this session, and I'm really grateful for his presence. I'm going to take you case by case and try and share some of the salient features of the 2021 guidelines of the European Association of Urology, and will take polls as well. So you will have an option, once I raise a question, then you will have an option to cast your vote, and we'll see what is the dominant view in certain situations. So the case number one, it's a 66-year-old gentleman. He's a controlled hypertensive, diabetic, history of ischemic heart disease. He is incidentally diagnosed to have a solid renal mass on a routine ultrasound. Subsequent CT scan showed a small upper polar lesion on the right kidney. He underwent open partial nephrectomy, and the pathology was T1A, which is meaning that less than 4 centimeter tumor, clear cell renal cell carcinoma. His preoperative creatinine was 1.4, and his postoperative creatinine is 1.5. So you all remember the trifecta and the pentafecta in RCC. So my first question is that should CT scan be done in the preoperative staging? And the second question is, what imaging should be used to detect disease status in the postoperative surveillance? So it is open for poll. For the first question, should CT be done in the preoperative staging? Yes, no, I don't know. Please start voting. Okay, so we'll stop voting now and we'll have the result. So Zishan, 70% believe that CT should be done in the preoperative staging of this tumor. What is your view?
Yes, sir, absolutely. CT chest, if we are talking about,
Yes.
then I think the incidence of metastasis is just under 1% in T1A tumors. And there has been, I think, a couple of studies going on. One is regional in Scotland as well, which again shows between 1 to 2%. So while metastasis could be missed, absolutely, even if it's 1 to 2 cases, but it's more to do, I think another factor is those non-specific lung nodules that needs to be kept an eye on, which are not really metastatic, and that can become really misleading if we find them on post-operative imaging and do not have the information about that pre-operatively. So I think both these factors, I would support CT chest pre-operatively for anyone going for treatment.
Okay, that's interesting. So can we move on to the next question, Sharif? So the next question is, right, the next question is, what imaging be used to detect disease status in the post-operative surveillance? Would it be a contrast CT? You can start voting now. Contrast enhanced ultrasound, MR with contrast or without contrast, or just a simple grayscale ultrasound, maybe with Doppler. Kindly vote now. Okay, so about 70% have cast their vote. And if we look at the results, it says that contrast CT should be what should be done in the post-operative. So over 80% have voted in favor of contrast CT. Some people have asked for an MRI contrast. About under 10% says that an ultrasound. And interestingly, 7% said contrast enhanced ultrasound. Thank you. So let's see what the guidelines say. So if you look at the EAU guidelines, the recommendation is that omit chest CT in patients who are incidentally diagnosed with the clinical T1A disease due to the low risk of lung metastasis. And as Ishan pointed out, that the incidence is 1 to 2% in the cohort that they've studied in Scotland. So I think from that perspective, CT is not recommended for general use. About the second question, that should a contrast CT or an MRI scan be done with contrast as a follow-up surveillance? For this low stage, low grade disease, the recommendation from the EAU is that non-ionizing modalities like an MRI scan without contrast, ultrasound, particularly contrast enhanced ultrasound, should be the predominant way of evaluation. We should remember that this patient had a slightly raised creatinine as well. So, and that's the reason why it is recommended that we should use non-contrast CT rather than non-contrast ultrasound rather than any other modality in the follow-up. If there is a doubt or issue, then again, you can move on to the contrast CT. Is my slides not clearly visible? Shall I move to the other, the full screen mode?
Yes, sir.
Okay. So after this slide, I'll move on to the full screen. So this is some of the key points about contrast enhanced ultrasound, which is not very widely available. But basically it use a gas agent with a shell. So this is various types are available in the market. The gas used is typically octafluoropropane and sulfur hexafluoride, and it is shelled in microbubbles with phospholipid or albumin. Now, contrast and enhanced ultrasound are good to delineate and characterize renal masses. Obviously, you need to be experienced in doing that. Clear cell carcinoma, the clear cell RCC is typically visible as hypervascular and heterogeneous masses, whereas papillary are hypo-enhancing throughout. So this is, you can actually differentiate between our clear cell and papillary tumors. Oncocytomas and lipid-poor angiomyolipomas are difficult to distinguish using contrast-enhanced ultrasound. So I'll just take less than a minute to move on to the next different mode of presentation for the slides to be visible clearly. Stop sharing. And it is coming more change. So is it better now? Okay, so this is case number 2, and this is a 46-year-old school teacher who had again an incidental diagnosis of an renal cell carcinoma, and you can see a CT scan. She had microscopic hematuria, creatinine was normal, and for this left lower polar lesion, she is planned to have a partial nephrectomy. She's concerned about prognosis and wishes to know what are her chances. So let's move on to the poll number 3. And Sharif, kindly share the poll number 3 so that the participants can vote. So you need to now vote as to what is the most important, or if they are all important, then all of the above, prognostic marker in the assessment of renal cell carcinoma patient undergoing partial nephrectomy. Okay, I think we can end poll because majority of you have voted, and very clearly, vast majority have voted that all of the above, which is tumor stage, tumor size, tumor grade, and RCC subtype, are all important in the prognostic workup of patients undergoing treatment for RCC. And you guys are right about this poll. So let's share another case, and then I'll give you the opinion from the EAU guidelines on this issue. So this case number 3 is a 30-year-old female who presented with menorrhagia and was undergoing workup for fibroid in the uterus with the CT scan. However, in that workup, she was found to have a kidney tumor. So on examination, she is obese, rest unremarkable, functional class 0, and this is her CT scan. So Zishan, I would request you to kindly just describe the salient features of this CT and how residents should be describing if they are shown this CT scan of chest and abdomen.
Thanks, Hammad. So from a description point of view, clearly start with the imaging modality. This is the contrast enhanced CT scan. Then the next phase is what parts of the bodies are covered. It's chest and upper abdomen, and the views. This is an axial scan, and then we just go on to the primary organ where the lesion is. That what exactly the phase is. So this looks more like a nephrogenic phase or portal venous phase, where we can clearly see a lesion on the left, on the left kidney, which appears cystic. It's not particularly enhancing compared to the rest of the kidneys bilaterally. We also need to comment on other organs, such as part of the liver we can see where there's no obvious lesion seen. Bowel seems slightly distended with a bit of gas, but again, there's no obvious findings on this view. Coming to the CT chest, again in this limited axial view, I do suspect whether there is any possibility of metastasis here in the left lobe around the periphery, and to completely comment on that, I just need to see all the phases and all the different views, including coronal and sagittal.
Right, wonderful. So I think this is the way that you guys should be describing in imaging, in which you should be able to tell what imaging is this, what phase is this, and what you are seeing. Don't just jump to conclusion. And this is one of the mistakes that people do make during their exam in their eagerness to describe. They just would say that this is an RCC, which is obviously wrong, and then you will have issues. As most of you have pointed out, that there is a small metastatic deposit in the lung. So I think most of you can see this deposit here, right? Okay. So the next question is what grading system be used, and should prognostic models be used? Should molecular markers be used in the prognosis? Okay. So we move on to poll number 4. Kindly, this is a longish thing, so we'll give you more time. So please read it carefully, and we will wait for 70–80% to answer the question before we'll stop poll or end poll. And I think Dr. Zishan made your answering this questions quite easy. Okay, so I think we have got a picture. More than majority of you have voted, so we can stop the poll now. And I think, Zishan, I would request you to please comment on the audience, and I'm quite impressed the way they have voted for this one. So what is your impression of each of these points?
So Kelly, the Furman grading system is what we use for grading from grade 1 to 4. Prognostic models definitely needs to be used, and we normally just use the Henge criteria which is modification of Memorial Sloan catering criteria previously described, which is a combination of certain blood tests, basically, including platelets and alk phosphase and calcium level, along with performance status, which in a metastatic scenario helps to characterize into low risk, intermediate, and high risk metastatic disease. And that is, this is also called as IMDC, International Disease Consortium. And that guides us regarding further management. As you could see, several trials has proved that cytoreductive nephrectomy is more useful in a low risk scenario compared to intermediate and high risk disease. So clearly prognostic model definitely should be implemented here. For molecular markers, again, there has been clearly mention of that because of the nature of renal cancers. They're vascular tumor, immunogenic tumor. But from a diagnostic stage point of view, there's not anything that we practically use which our decisions are based on. So yeah, that would be my opinion regarding further treatment plans. Yeah.
Yeah, thank you very much. So I think if you look at the guidelines in RCC patient tumor stage, grade, and RCC, this is in response to the question that we had earlier, provides information. The WHO and International Society of Uropathology grading system is the slightly modified version of Furman. It has given some more objectivity to the grading system, and it is strongly recommended. The prognostic models be used for both localized and metastatic disease. So, and Dr. Zishan talked about the IMDCC model, which is HANGS, previously called HANGS, and this is particularly used for patients undergoing systemic therapy using tyrosine kinase inhibitor or ICI. And he's absolutely right. And all of you have also agreed that we don't need to really use routinely the molecular markers in the day-to-day clinical practice. Okay, so we move on to our next case. And our next case is a 56-year-old gentleman, a poorly controlled diabetic and hypertensive. He's a landlord, smoker, creatinine of 1.5, hemoglobin A1C of 10.3. He presented with hematuria with clots for the past 3 months. And a CT scan shows a 7.2 centimeter lower pole RCC with no lymphadenopathy. If you look at the CT scan, and this is just one picture, but I can show you that in all the scans, his right kidney is slightly smaller. So we are dealing with a 7.2 centimeter, which is T2, cancer of the left kidney, whereas the right kidney is a small. So the next poll is, should he be considered for partial or radical nephrectomy? And Sharif, you can share the poll now. So T2, clinical T2, 7.2 centimeter, left lower polar tumor. Would you go for partial nephrectomy or radical nephrectomy?
Yes. FCPS का course
So thank you very much. I think we can end poll now. So this is wonderful. Majority thinks that one should do a partial nephrectomy, although we know that the classical indication for partial nephrectomy is a T1A disease, typically T1A, which is less than 4, but some indication for T1B, which is 4 to 7 centimeters. This is 7.2 centimeters, which is really T2. So majority of you believe that partial nephrectomy be done in this case. Would you consider this an appropriate decision, Zishan?
Yes, Prof, absolutely. It's really pleasing to see approach of our residents. Clearly, the guidelines, I think they're gone up to T1, and it doesn't really matter the size, but it's to do with the exophytic and endophytic proportion. And from the single slice you're shown, it seems like a very partialable tumor with not a huge endophytic component. So I think it would be really beneficial for the patient. And it should be a very, it should be done without a lot of technical challenges in the partial
Right.
display. Yeah.
So you're right, and I'm really very happy that majority of participants have very correctly voted that although it is not a good quality evidence is available, but generally this is what most of us will do if there is an expertise available to do a partial nephrectomy, so that we preserve his renal, his nephron as much as possible, considering that he has two diseases which can potentially cause CKD, and he has a smaller kidney on the contralateral side. So absolutely right that this patient should have a partial nephrectomy and not radical nephrectomy. So the second, we can go to the next poll. Poll number 6, please. Sharif, can we share the next poll, please? The next question is, should one do a lymph node dissection during this particular case? No, poll number 6, this is already done. Yeah. So should one do a lymph node dissection during kidney cancer surgery? It should be done because it has a therapeutic advantage. It should be done because it has provided diagnostic advantage, and no, it should not be done. So far, majority is in favor of not doing one when there is no CT evidence of lymphadenopathy. The second strong group is yes, it has diagnostic or prognostic significance, and a very small percentage, less than 10%, think that it has a therapeutic advantage. So thank you. I think that's wonderful again. So I don't really, it seems that I should not be making this presentation. Most of you know the correct answer to everything. Wonderful, very impressive. Okay, and this is the guidelines also recommendation. So although the evidence is weak, the strength of rating is weak, but offer partial nephrectomy for T2 cancers in a solitary kidney or with chronic kidney disease if technically feasible, and do not offer an extended lymph node dissection to patient with organ confined disease. So I think spot on. Let's move on. Now, this is case number 6, a 46-year-old lady, doctor, she's a physician, surgeon, and in fact, trainee surgeon. She presented to the emergency room with acute flank pain and urinary tract infection. Her ultrasound was suspicious, so she was advised a CT scan, and this is a CT scan that you can see. And now CT scan is quite clearly showing a solid lesion, not as enhancing as the rest of the parenchyma, but again, as Zishan pointed out, that it is really related to the phase in which you have taken the CT film. So she's considering lap partial nephrectomy, and however, she underwent an open partial nephrectomy ultimately. This is the specimen, and this specimen shows clearly that the part of the kidney margin have been taken along with it, as you can see in the upper part. This is the normal kidney tissue. This is the tumor itself. And the question really is that lap versus open for partial. And I will put this question to Dr. Zishan. What do you think is the advantage of lap versus open partial?
Certainly, Prof, if we speak about a surgical colleague who has got adequate expertise and experience with lap partial, and that's the kind of mentor I was trained with. I have not pursued myself, but clearly there are advantage in terms of morbidity, post-operative morbidity. There's technically a lot more challenging procedure, especially this kind of a tumor with some endophytic component. The chance of positive margin and post-op bleeding is slightly higher as well. But if go past that stage, then the post-operative recovery is a lot more quicker. Long-term wound pain effects, they can be all prevented, and time to convalescence is significantly better. So, yeah.
So, I mean, shorter hospital stay, less blood loss, not significant oncological advantage as such. So this is something that you should answer if you are asked this question in the examination, that open versus lap partial, what is the advantage of one over the other? But the important thing in cancer surgery is then don't do a lap procedure if you're not really good in doing it. It's a difficult undertaking. And the most important thing is that this patient should have a clear margin and achieve the pentafactor, or at least the trifactor, so that you're going in for an oncological procedure. If you can do a good open, please go ahead and do a good open, or refer the patient, if she's very insistent on getting a lap, to a center which is doing regular lap partials.
Just to add, Prof, I think European guidelines speak about exactly the same, that if you don't have expertise, then open is completely acceptable, open partial.
Yeah, thank you. So this 66-year-old lady and had this tumor, which is very endophytic. And because of the size consideration and the little impression that she may not be really going into the collecting system, she undergoes an open partial nephrectomy. What we had is this histology, which is essentially showing a positive surgical margin. So the question really is that once you get this positive surgical margin, the 66-year-old lady who had a T1B tumor, slightly more than 4 centimeters, what would you do next? I don't know if we have a polling question on this one. Probably not. Okay. So, no. Right. Sorry. We have a poll on this. Please share the poll, poll number 8. Okay. So if you have done this partial and there is a positive surgical margin on the histopathology report, this is okay. So this has already been addressed. Anyhow, okay. We can go for poll 8, Sharif. Right. So should an immediate radical nephrectomy be performed for positive surgical margin? Please vote now. Okay, so I think we can end poll now. I think, Zishan, they have all very correctly pointed out here, over 80% that no immediate radical nephrectomy is not required if you even have a positive surgical margin. And if we look at the guideline, radical nephrectomy after positive surgical margin can result in overtreatment in many cases. Although the level of evidence is 3, but this is the current recommendation that patients should not undergo immediate radical rather than be on surveillance for if they have a surgical margin. So you can intensify the follow-up of these patients with positive surgical margins rather than going in and nephrectomizing them.
The recurrence rate is, I don't think it's more than 20% in various series, between 10 to 20%. But if it's combined with a T3A status, then that becomes more significant. But again, we can start with observation.
Okay, so there is a question about the pentafactor and the trifactor. So as the name indicates, the trifactor are three criteria of a good quality partial nephrectomy, which essentially means that you have no positive surgical margin, you have a warm ischemia time of less than 25, and there are no major complications. So if you achieve these 3 things, this is trifactor and pentafactor, 2 additional factors, which include 90% of kidney function preservation and no development of new CKD higher grade within 1 year. So this is trifactor and pentafactor. Right, so this is another case, case number 8, 76-year-old lady, known case of diabetes and hypertension, had an ultrasound for microhematuria, which shows a small solid renal mass, and a subsequent CT reconfirmed this to be part endophytic, part exophytic, small, really T1A lesion. So in your practice, Ishan, would she be a candidate for surveillance, or would she be a candidate for some form of thermal ablation, or even lab partial?
In this age group, she's 76 and known case of diabetes and hypertension, so no major medical comorbidities. The lesion, I don't know, it looks not more than 2 centimeters. So clearly, if we look at the various series, including Michael Jivitz, then from 2011, then this is an ideal case where we can just simply monitor it just for the time being. We do it for a total period of up to 4 years. But at the same time, depending on patient's attitude, if she comes across super fit with performance status of 0, then biopsy and thermal ablation, thermal or cryoablation would be the preferred option. But I wouldn't think that partial would be really advocated for such a small lesion, 76-year-old.
Right. Thank you. So the poll and the question number 9 is there a size limit to use of thermal ablation for small RCC? And the option is yes, there is. No, there is no size limit. And the third option is size limit is different for RFA, which stands for radio frequency ablation, and for cryo. Okay, so I think we can stop and I mean, answer number 1 and 3 are actually correct. That yes, there is a size limit for thermal ablation, and this size limit is slightly different for RFA and cryo. And I'll show you the guidelines and the recommendation soon. So we can move on to next poll number 10. and then I'll show you the answer for both the questions. So the question number 10 is, when should a biopsy be done for patient planned for thermal ablation, either cryo or RFA? And can we have the next poll, please? Sharif, can we have the next poll, please? So, okay. So not. I think this is wrong. No, this is wrong. The question should be. Okay, I think there's some mistake here, but anyhow, so never mind. I take this out. This is about lymph node dissection, which has already been addressed. So there's some mistake here. So anyhow, the question really was that should you do a biopsy and in the same sitting do the thermal ablation, or should you do a biopsy first, wait for the result, and then do thermal ablation? And if you look at the guidelines, there is low quality evidence suggests that high disease recurrence rates after radiofrequency ablation of tumors of greater than 3 centimeters and cryo for greater than 4 centimeters. And again, there is low quality evidence that comparison to partial nephrectomy is not really, we don't have a good quality evidence to suggest either one. So for patients, and Zishan correctly pointed out, who are frail, who are aged, and they have small lesions, then they should be really on active surveillance, because the growth rate of small renal cancer is not more than 1 millimeter per year. So by the time they have reached 80 years of age, the tumor would be about 3.5 centimeters, which means that they would still be in a very low risk for metastatic disease. The question about performing a percutaneous renal biopsy, it is guidelines strongly recommend that the biopsy be done prior to and not concomitant with thermal ablation. So when you are going for thermal ablation or active surveillance, one has to discuss obviously the complications and the oncological outcome, and do not routinely do thermal ablation for tumors greater than 3 centimeters by cryo or greater than 4 centimeters by RFA and cryo. Okay, so move on to the next case, and this is a 72-year-old, 60-pack year history of smoking, presented with gross hematuria, no other comorbidity. He is ECOG1, and this is a CT scan. And as you can see, that this CT scan shows a locally invasive tumor, which is going posteriorly towards the posterior abdominal wall. And there is a very ill-defined fat plane between the tumor and the posterior abdominal wall. You have invasion of the psoas major muscle. You have an aortocaval lymph node here as well. He undergoes a CT scan, and as you can see in the CT where the arrow is showing that you have a metastatic lung disease as well. And then some small lung nodules. So in a situation like this, we move on to poll question number 12, that what would you do a lymphadenectomy in this case? This is the question. Okay, so Dishan, majority thinks that lymphadenectomy at this point, and I'm not talking about template lymphadenectomy, but sampling lymphadenectomy, it provides staging and prognostic information. Do you agree with this approach?
No, Prof, I think this is the first time I have to slightly disagree. I presume we are going for the cytoreductive nephrectomy. We've already decided on that.
Yeah.
Now, this patient has got a few pulmonary deposits, which means that he's going to go down the line of systemic treatment post-operatively, if not immediately, even if we decide to observe it, then sooner or later. And I think in that case, clearly that goes against, again, it's a case against not going for lymphadenectomy, especially when it's not going to change really the prognosis. It will give some more prognostic information. So just to avoid any making the procedure more morbid, I would not recommend that. Okay. Because it's not going to cure the patient. He has metastatic disease already.
Yeah, and particularly when the lymph node is really lying in a difficult area, which is the aortocaval window.
Yes. Yeah.
Okay. Can we have the next poll question? Question number 12. Okay. So if there are multiple lymph nodes, if there are multiple pulmonary deposits in this patient, what should be the approach? Should it be a cytoreductive nephrectomy and surveillance for lung nodules, give upfront systemic therapy plus minus cytoreductive nephrectomy, give systemic therapy only, or present the case in the tumor board so that a multidisciplinary team decides on the management? Okay, I think we can end poll now. And I think these are interesting answers because there is probably not one approach which is absolutely right, particularly in the light of some of the recent RCTs about use of sunitinib as a first-line treatment versus followed by plus minus cytoreductive nephrectomy versus cytoreductive nephrectomy followed by systemic therapy. So in situation, some of the people would probably not require a cytoreductive nephrectomy. So I think that's what the majority thinks, and probably they are right. And let's look at what the guidelines say. So in patients with locally advanced disease, the survival benefit of lymph node dissection is unproven, but lymph node dissection helps in staging and prognosis patient. So in cases of metastatic disease, discuss surgery within the context of a multidisciplinary team. And the whole idea is to have a comprehensive look at the patient from the clinical viewpoint about his or her fitness, ability to undergo and have and the availability of the various agents. So it's best that decisions are made in a multidisciplinary team because there is no very clear answer to this situation. So the next poll question is that, can we share the next poll? So this patient, for example, with locally advanced disease and a lymph node undergoes surgery with no lung nodule. He undergoes surgery and subsequent CT scan showed no CT evidence of disease. Should he be given, knowing that he is locally advanced, and probably we would not have made him disease-free, should he be given some form of a systemic treatment like sunitinib or everolimus or immunotherapy? Okay, I think we can end poll now. And the consensus majority think that he should be given some form of a systemic treatment. Dishan, any views on this one? No CT evidence of disease,
Yeah,
but locally advanced disease with node, which one node was removed.
Yeah. I think, again, I have to say the way the resident been thinking is because of the so much literature that keeps coming up, which mixed results. But at the end of the day, there is, again, this has not been accepted as a standard practice in UK practice or in European guidelines. I think that any adjuvant treatment is advocated. There has been some role of immunotherapy, and very recently pembrolizumab. I think over the last few days there's another result came up, but again these are very short interval follow-ups. So I wouldn't think that that would have any advantage significant.
Yeah, so I think you're absolutely right. There is do not offer adjuvant therapy with sorafenib or pazopanib or everolimus and some of the other newer agent. So that's really not indicated. So if there is no evidence of disease, you would not be able to quantify what you are treating and if there is a response or not. And these are not really candies. They have their own set of side effects. Okay. Let's move on. So we have cross time. Do you guys want me to continue? I have, I think, 2 or 3 more cases, or we can stop here. Carry on. Okay. So, so this is a 77-year-old female with weight loss, flank pain, shortness of breath on exertion. CT abdomen and the CT chest were done, and this is the CT abdomen, and you can clearly see that there is a large tumor which is involving the renal vein. The gonadal vein is also involved, and this is the non-contrast CT, and this is her chest scan. And can somebody tell me what are the 2 findings in this chest scan or chest CT? Or you can write in the chat box. Okay. Well, the 2 things which are there, and obviously you can see. Oh, yeah, I mean, absolutely right. I mean, it cannot be in the current setting in which we are discussing. This could be COVID as well. We are passing through a pandemic. But this is significant pulmonary disease with metastasis, and she has cardiomegaly and significant cardiomegaly. Dr. Ejaz Shah has written cardiomegaly. So wonderful. Yes, she has cardiomegaly. So medical evaluation showed that she has uncontrolled hypertension, left heart failure with decompensation. She is Hep B, Hep C positive. And this is all her medical evaluation. And this was her ECG. Can somebody tell me what is this ECG showing? It's an unfair question to a urology resident, but any bright medically oriented minds? Okay, so basically what you are seeing is multiple peaks, Q waves, long QRS complex, and this is what is the French called torsades de pointe, which is characterized by those peaks and long QT interval. It can be totally asymptomatic, but it can also be showing that the patient has a failing heart. So this is not atrial fibrillation. This is basically torsades de pointe. So this patient was obviously counseled, and she didn't decide not to receive any kind of treatment, and obviously she's not medically fit to undergo any kind of treatment. This is another case, very similar, and you can see a lot of metastasis all around. The lungs are full of metastasis. There are multiple liver lesions and a left renal cell carcinoma with left renal vein thrombus. So obviously not a surgical candidate. Can we have the poll number 14, please? What would be the first line treatment in this patient if he is fit to undergo medical or surgical treatment? Would it be ICI? ICI stands for the immune checkpoint inhibitor, which Zishan just pointed out about the recent data of pembrolizumab. TKI, that's not EKI, it's TKI, tyrosine kinase inhibitors, systemic chemotherapy, radiation therapy. Okay, so thank you. So majority of you think that ICI, which is the immune checkpoint inhibitors, if it is available, obviously its availability and its cost is a major issue. Does NHS provide pembrolizumab, Zishan?
Yes, not exactly pembrolizumab, but immunotherapy has it is being funded now and given in combination
Okay.
along with TKIs. Yeah.
Okay. Yeah. So, yeah. So this patient received immunotherapy, and this is what is recommended. So 3 months of ICI, and subsequent step was to discuss, if the patient has responded very well, to discuss if cytoreductive nephrectomy is going to give additional benefit to this patient, particularly if the metastatic deposits have significantly shown significant improvement on subsequent CT scans. Okay, I think I should stop here now. We have actually really crossed the time. And if there are any burning questions, any points that you have with me or Dr. Zishan, please, you can ask your questions now. Oh, so there is demand to continue with the presentation. I have only 2 more cases. If you want me to continue. Okay. Very well. Ilm ki pyas. Right, so this is case number 13, 56-year-old lady with left renal mass. She had left radical nephrectomy 2 years back, CT at 3 months, 1 year, and 18 months. were unremarkable. However, the CT scan at 2 years showed this was the primary lesion for which she underwent a radical nephrectomy, and she remained okay for 1.5 years after surgery. But after 2 years of surgery, this is what she has. So she has bilateral adrenal metastases. And if you look at the primary scan, so you can see the very nice, normal looking adrenal hair, a V-shaped structure. There's another normal adrenal on the left side. So they were perfectly okay and they remained fine for 1.5 years after surgery. But this is how cancers are. I mean, they can really come back in mysterious way. So she had a bilateral adrenalectomy and she was obviously placed on fludrocortisone replacement therapy. And her PET scan 6 weeks later showed no evidence of disease. Okay, so the question to the audience now, poll number 16, please. Sharif, can you share poll 16? So after having bilateral adrenectomy and knowing that she may have micrometastatic disease elsewhere, she should be given some form of a consolidation treatment in terms of tyrosine kinase inhibitors or immune checkpoint inhibitors, or should she only be on close surveillance? Okay, I think we can end poll now, and there is very clear indication that vast majority have learned from the previous case that if you do not have imaging evidence of disease, there is no point giving a little tadka of systemic therapy. Would you agree, Zishan?
Yes, I absolutely agree. There's no tadka in renal cancer, despite being tried several times.
Yeah.
But I don't think they're coming up with any answers to that.
Right. So thank you. Let's move on. So we have asked this question, and this is what the 1B evidence available that tyrosine kinase inhibitors treatment after metastasectomy, there is no evidence that disease would not improve after RF. So basically, it is not better than observation or placebo. So there's a good quality evidence, and the recommendation, which is a strong recommendation coming from 1B evidence, is that do not offer a TKI after in MRCC patients after metastasectomy with no evidence of disease. Okay, so just a little picture for you, and this is how the RCC metastasize: lymphatic circulation, venous circulation, and systemic circulation. So in all these 3 ways, the RCC can metastasize, and depending upon which route the tumor has taken, you would have metastatic deposit coming either in liver or above the diaphragm into the lungs, which is one of the most favored site for RCC, or to para-aortic lymph nodes. So because we see such varied pattern and there is no clear way that, so there's beautiful articles in Radiographics, I've read it many years back, describe why certain types of tumor goes to certain areas. Okay, so probably one of the last cases for this evening, 74-year-old male, recurrent RCC, status post left nephrectomy in 2013. had a suspected recurrence in a recent MRI scan, which was done because he was undergoing spine surgery for some disc-related issue. And then obviously a proper MRI scan was done, followed by FDG PET scan for restaging. And this is his PET scan. And as you can see in this PET scan, there is a PET-avid large nodal deposit, which was reported to be adrenal and a para-aortic lymph node, along with another deposit on the psoas major muscle. So these two deposits were there, and the rest of the scan was really unremarkable. 74-year-old father of a consultant physician, and she insisted that we should do something definitive. We considered many options, discussed the case in the tumor board, and in view of two isolated and really a oligometastatic disease, we did a metastasectomy. And really in these situations, IMDCC calculator is really helpful. So because the time frame from diagnosis to systemic therapy was, or not systemic therapy, but any therapy after that was long, his performance status is good, and all these other parameters were also favorable. He had a good prognosis. So he really falls into the good prognostic group. So he was offered metastasectomy, and his first PET scan after the surgery is indicative of no evidence of disease, but he will be in close follow-up. So when you're using these calculators, it's important that you use it and then subsequently decide treatment. So if you have 0, it is called a favorable risk IMDCC. If you have 1, 2, then it is intermediate risk. And if you have more than 3 points, then this is a poor risk. And patients who have favorable risk, the standard of care with metastatic RCC is use of pembrolizumab or some of the newer tyrosine kinase inhibitors. Pembrolizumab is really the immune checkpoint inhibitor. The alternative treatment, if you don't have access to these, or they are not available, or they're too expensive for use, is sunitinib or pazopanib. These are alternative. But if you have poor risk stratification, then again, the options are very similar. So summarizing the guidelines, the functional follow-up after curative treatment RCC is useful to prevent renal and cardiovascular deterioration. Oncological follow-up can detect low recurrence or metastatic disease while the patient may still be surgically curable. So that's an important way. The prognostic model really provide you a guideline on how to treat patient. And the life expectancy estimation is feasible in order to counsel patients about various non-invasive modality for treatment. So with this, I'll stop here, and I am looking at the chat box to see if there are any questions. So how about a 7-centimeter tumor and a solitary lung lesion, 30+ pack year ECOG? Okay, fine. ECOG 2, 55-year-old male. So Zishan, is a question by Dr. Shoaib Mithani, is from Kidney Center, about 7 centimeters RCC, solitary lung lesion, 30 pack years of smoking history, 55 years of age, ECOG 2, and he had coronary stenting about 8 years back.
Right. So yeah, with a performance status of 2, Clearly, that that would make it a bit more morbid for the patient. But considering solitary lung lesion, patient is still young. He had his coronary stenting done, and I mean, if we know that he's keeping it stable, then we have to give him maximum chance of following the same routine and following the same path of management as you would do in any of the 55 years of age, in my opinion. So I think we should go for a cytoreductive surgery and followed by observation of this solitary lung lesion. Yes, we need good counseling regarding the morbidity involved with that.
Yeah. So really, I'm really grateful for all the audience who have stuck on for that long and enjoyed this presentation and actively participated. Tomorrow, we are going to start off a little at 6 p.m. and we are going to have a uroradiology session in which some really interesting imagings will be discussed. And we are very fortunate, Dr. Basit Salam, who's our radiologist, will be there to explain these things. And then we'll also talk about PET scan, PSMA scan, and MP-MRI, and how to look at these. And we'll talk about pertinent things which are there from your examination point of view. So this will be 6 to 7 p.m. At 7, we're going to have a talk on urinary incontinence and how to make a clinical diagnosis. And in the last session of Tuesday would be on urodynamic tracings and how to read them and how to interpret them by some of the dedicated people who work in the area of female urology and functional urology. So thank you very much and have a good evening. And I really thank my co-presenter, Dr. Zishan, for his valuable input into today's presentation and for guiding all of you to take your exam in the best possible frame of mind. So thank you very much, Zishan.
Thanks a lot, sir.
Very good evening to all of you.
All the best.